Have you ever stopped to think about your body's own defense system? I mean, it's pretty incredible, always working away. But what happens when it maybe goes a bit haywire, attacks your own body? Or, when we need to dial it back carefully? Today, we're doing a deep dive into a really fascinating type of medication immune suppressants. And we're going to focus particularly on a pretty cutting-edge group called immune modulators. Our goal here is to unpack how these drugs work, what kinds of tricky conditions they help manage, and importantly, what you need to know about using them safely. We're drawing on our shared source material for this. Okay, let's get into it.
Yeah, it's amazing stuff. What's really fascinating, I think, is how incredibly precise these drugs aim to be. They're interacting with this really intricate defense network in our bodies, and it's all about finding a delicate balance, not just hitting the off switch, but modulating. Carefully adjusting.
That's a really important point, because when we talk about immune suppressants generally, they're often paired with corticosteroids, aren't they? Those primarily tackle the inflammation itself, the initial damage.
Exactly. Corticosteroids are often the first line for that quick anti-inflammatory hit. And these broader suppressants are absolutely vital in things like organ transplants. Preventing rejection is key there.
Right.
And also for a whole range of autoimmune diseases where the body's attacking itself.
Okay. So our sources mention different kinds of suppressants.
Yeah, they lay out a few categories. You've got the immune modulators, our main focus today, but also things like T and B cell suppressors, interleukin receptor antagonists, and monoclonal antibodies.
Monoclonal antibodies, quickly, what are those again?
Think of them as highly specific guided missiles. They're engineered antibodies from a single cell line designed to lock onto very specific targets, like certain immune cells or proteins.
Got it. Right. Very targeted.
Very targeted. But like you said, today we're really zooming in on the immune modulators. They're kind of the stars of this particular deep dive.
So what makes them stand out? They're relatively new, you said, and exciting. How do they actually modulate? What's the mechanism? This is where it gets really interesting, I think.
It really is. Yeah. So the core idea is that these immune modulators work by blocking the release of various cytokines.
Cytokines, those are the messenger molecules, right?
Exactly. They're key signals in the immune system. They sound the alarm, get the inflammatory response going, activate lymphocytes. Those are your main immune cells.
Okay.
So by blocking the release of these chemical messengers, these drugs basically dial down the overall immune activity, but often in a more targeted way than older drugs. The end result is immune suppression, yes, but achieved more subtly.
So less of a sledgehammer, more like snipping specific communication wires.
That's a pretty good analogy, yeah.
Yeah.
Intercepting those signals that tell the immune system to go full throttle.
Can you give us some actual drug names? Ground this a bit. Our sources mention, let's see, fingolimod, Gilenya.
Yep, fingolimod, Gilenya, that's a big one.
Like thalidomide, Revlimid.
Lenalidomide, and thalidomide or thalamid. Those are key examples.
Thalidomide has a history, of course.
It does, a very significant one, which we need to touch on later with safety. But its mechanism as an immune modulator is why it's used now for specific conditions. And there are others too, like apremilast, dimethyl fumarate, teriflunomide, pomalidomide. It's a growing class.
Okay, great. So that leads us nicely into the why. What specific jobs do these drugs do? What conditions do they treat? They seem to have quite diverse effects.
They really do. And the way they work can be quite specific. Let's take lenalidomide and thalidomide again. Our sources say they actually do two things. They stop the release of proinflammatory cytokines, the ones that fuel the fire, so to speak.
Okay, dampen the bad signals.
Right. But they also increase the release of anti-inflammatory cytokines from certain white blood cells called monocytes.
Ah, so they boost the calming signals too.
Exactly. It's a dual action to help rebalance things. Plus, they affect how quickly certain cells grow, which is relevant in cancers like multiple myeloma.
Interesting. What about fingolimod? You said that one was unique.
Yeah, fingolimod's mechanism is quite different. Imagine your lymph nodes are like barracks for your immune soldiers, the lymphocytes.
Okay.
Fingolimod basically traps lymphocytes in those lymph nodes. It stops them from getting out into the bloodstream and traveling to places where they might cause inflammation, like the brain in MS.
Wow, so it keeps them contained.
Pretty much. And a key thing about fingolimod, it was actually the first oral drug for relapsing forms of multiple sclerosis. Before that, it was mostly injections, so that was a big deal for patients.
That's huge. Oral options make such a difference. Okay, so let's run through the conditions quickly. Lenalidomide, you mentioned multiple myeloma, also myelitis blastic syndromes.
Correct. Those are bone marrow-related disorders.
Thalidomide, also multiple myeloma, and something called erythema nodosum leprosum.
Yes, that's a complication of leprosy, a specific skin inflammation.
Okay. A pre-list? A newer one.
Primolisate, yeah. That's approved for psoriatic arthritis in adults.
And for MS, besides fingolimod, there's also dimethyl fumarate and teriflunomide.
That's right. More options for MS, which is great.
And pomalidomide, related to thalidomide.
Yes, it's an analog, chemically similar, also used for multiple myeloma, often when other treatments haven't worked.
It really shows how targeted they're becoming, different drugs for different pathways and different diseases.
It absolutely does.
Oh.
It's a big shift from just broadly suppressing immunity. Often means potentially fewer widespread side effects compared to older approaches, though they still have significant risks we need to cover.
Right. That precision is definitely the theme here. Okay, let's shift gears slightly. How do these drugs actually travel through the body? Their pharmacokinetics, absorption, metabolism, how long they stick around. Why is understanding this journey so important?
Oh, it's crucial. It dictates everything from how often you take the pill to how fast it works, how long side effects might last if you get them, potential drug interactions, all of that.
And our sources show they're quite different.
Very different. It's fascinating. Take fingolimod again. It's absorbed slowly, takes maybe 12 to 16 hours to reach peak levels.
Wow, that's slow.
It is. And get this, its half-life is super long, like 6 to 9 days.
Days. So it stays in your system a long time.
For a very long time.
Yeah.
That allows for once-a-day dosing, which is convenient. But it also means if you have a side effect or if you need to stop it for surgery, it takes ages to clear out.
That makes sense. Okay, contrast that with another one.
Sure. Look at thalidomide. Absorbed really fast peaks in maybe 30 to 90 minutes.
Much quicker.
Much quicker. And its half-life, only about 3 hours. It's in and out relatively fast.
Big difference.
Huge difference. Or dimethyl fumarate peaks in 2 to 2.5 hours. Half-life around just 1 hour. And interestingly, it's mostly broken down by enzymes throughout the body and breathed out as CO2.
Breathed out. That's unusual.
It is quite unusual for drug excretion.
And
Thalidomide, absorbed very slowly, 3 to 6 hours peak. Metabolism, we actually don't fully know. Excreted in urine, half-life 12-24 hours.
so much variation. Teriflunomide.
Peaks 1 to 4 hours, mainly excreted unchanged in bile, sticks around a while, most gone within about 3 weeks.
Pomalidomide.
Peaks 2-3 hours, metabolized in the liver, urine excretion, half-life 7.5 to 9.5 hours.
And ipirlimumab.
Peaks around 2.5 hours, liver metabolism, excreted in urine and feces, half-life 6 to 9 hours.
It really hammers home that these aren't interchangeable even within the same class. Each has its own distinct profile.
Absolutely. Doctors have to consider all this when choosing the right drug for the right person.
Which brings us inevitably to the really critical part, safety, contraindications, cautions. These are powerful drugs. So what does this all mean? What are the big warnings?
Well, this really raises the important question, how do we manage these powerful therapies carefully? And the single biggest warning, the most significant contraindication highlighted in our sources for all of these drugs is pregnancy.
All of them.
All of them. They are absolutely contraindicated during pregnancy. There's a high risk of serious harm to the fetus because these drugs can interfere with rapidly dividing cells.
So this isn't just a minor warning.
Not at all. It's a critical safety mandate. For anyone who could become pregnant, the sources stress they must use effective contraception. Often barrier methods are specified. And, crucially, proof of a negative pregnancy test is required before starting and then usually periodically during treatment. It's non-negotiable. Strict protocols are often in place, like the REMS programs in the U.S. for drugs like thalidomide and lenalidomide.
That's incredibly important for listeners to understand. The potential risks are that serious. Any other major contraindications?
Yes. Our source specifically mentions teriflunomide shouldn't be used in people with severe liver problems, severe hepatic impairment, because the drug itself is tough on the liver and could make it worse.
Okay.
So the bottom line here is that these medications require really strict medical supervision. Careful patient selection is key, and thorough education for the patient about the risks, the benefits, and what they need to do, especially regarding pregnancy prevention, is absolutely essential.
It really underscores that the benefits have to be carefully weighed against these significant risks.
Precisely. The benefits can be life-changing for people with these difficult conditions, but patient safety has to be paramount.
Well, this deep dive has certainly shown us just how sophisticated these immune modulators are. It's not just about suppression anymore. It's about precise adjustment of the immune response for conditions like MS, multiple myeloma, psoriatic arthritis. We've covered a lot. They're clever mechanisms, those unique journeys through the body, the pharmacokinetics, and so importantly, those critical safety considerations.
This has been fascinating to unpack. Perhaps a final thought for you, the listener, to consider. As we continue to discover and develop these incredibly targeted immune therapies, how does that reflect our deeper, evolving understanding of these really complex diseases? And maybe, what new frontiers could this open up? Thinking about truly personalized medicine tailoring treatments even more precisely to an individual's specific disease and their unique immune system. Where might that take us next?